My name is Aurelius, and I'm a student researcher studying suicidal ideation, self-injurious thoughts, and behaviors. Suicide represents one of the most significant public health challenges of our time, affecting millions of individuals and families worldwide. The World Health Organization estimates that suicide accounts for 1.3% of the global disease burden, with more than 720,000 deaths each year. This staggering figure represents more than just statistics. It reflects profound human suffering and loss that ripples through communities and societies. Understanding the etymology of suicide is crucial for developing effective prevention strategies and reducing this devastating burden. The complexity of suicidal behavior involves intricate interactions between biological, psychological, and social factors that we must examine systematically. This presentation will explore the comprehensive landscape of suicide epidemiology, from demographic patterns to risk factors and prevention strategies. This is the main point of our discussion today, and now we will delve deeper into the specific information that shapes our understanding of this critical public health issue. Demographics, sex, age, and race patterns. The demographic patterns of suicide reveal profound disparities that highlight the complex interplay of biological, social, and cultural factors in suicidal behavior. Men die at approximately 3 to 4 times the rate of women, with non-Hispanic white men showing the highest suicide rates at 22.0 per 100,000 people compared to just 1.8 per 100,000 for black women. These stark differences persist across all age groups and racial categories, suggesting that gender-related factors such as method choice, help-seeking behavior, and social expectations significantly influence suicide outcomes. Age patterns vary dramatically by race and sex, with white men showing increasing rates with age, while black men experiencing peak rates in their 20s and 30s. The baby boomer cohort born between 1945 and 1965 has emerged as a particular concern, showing elevated suicide rates as they move through middle age. Black women consistently maintain the lowest suicide rates of any major demographic group, a pattern that merits further investigation to identify potential protective factors. These demographic patterns underscore that suicide prevention strategies must be tailored to address the specific vulnerabilities and strengths of different population groups. Methods of suicide and geographic variation. Firearms remain the predominant method of suicide in the United States, accounting for 51% of all suicide deaths in 2010. Through this represent a decline from 59% in 1996. This decline in firearms-related suicides is encouraging from a public health perspective, as the overall suicide rate is largely driven by firearm suicide rates of 6.1 per 100,000. Suffocation has emerged as the second most common method, with rates of 3.1 per 100,000, followed by poisoning at 2.1 per 100,000. The strong correlation between household firearm ownership and suicide rates have been documented through multiple studies, with every 10% decrease in household firearm ownership correspondingly to significant declines in firearm suicide rates. Geographic variations in suicide rates closely mirror patterns of firearm availability and cultural attitudes toward firearms, with the western and mountain states showing consistently higher rates. The fact that 70% of deaths occur in the home, with the majority being firearm suicides, highlight the critical importance of means restriction and safe storage practices. These patterns suggest that public health approaches focusing on reducing access to lethal means, particularly firearms, could significantly impact overall suicide rates. Non-fatal suicidal behaviors, prevalence, and patterns. Non-fatal suicidal behaviors represent a different demographic profile than suicide deaths, with important implications for prevention and treatment strategies. Lifetime prevalence rates for suicidal ideation ranges from 2.6% to 15.6% across different studies and populations, while suicide attempts range from 1.1% to 5%. 12-month prevalence rates are lower but still substantial, with the suicidal ideation affecting 1.5 to 3.3% of adults, and suicide attempts occurring to and 1.2% to 1.7% of the populations annually. Unlike suicide deaths, women consistently show higher rates of non-fatal suicidal behavior than men across all age groups and racial categories, a pattern that has generated extensive discussion about gender differences in method choice and help-seeking behavior. Younger age groups demonstrate significantly higher rates of non-fatal suicidal behavior compared to older adults, contrasting sharply with the age patterns seen in suicide deaths. The higher rates among women may reflect differences in methods, lethality, with men more likely to use firearms, while women more commonly attempt suicide through less lethal means such as poisoning. These patterns indicate that prevention strategies must address both the high lethality associated with male suicide attempts and higher frequency of non-fatal attempts among women. Mental health and psychiatric risk factors. Mental health disorders represent the most significant and consistent risk factor for suicidal behavior, with over 90% of adults' suicide deaths associated with psychiatric conditions. Mood disorders, particularly major depression and bipolar disorder, account for approximately 50% to 60% of suicide fatalities among both men and women, making them the largest diagnostic category among suicide deaths. Substance use disorders ranks as the most frequent disorder found among adults who die by suicide, with alcohol abuse and dependence being particularly prevalent. The presence of multiple psychiatric disorders dramatically increase suicide risk through dose-response relationship, with individuals having 2 or more diagnoses showing substantially higher rates of suicidal behavior. Previous suicide attempts consistently emerge as one of the strongest predictors of future attempts and completed suicide, particularly in the context of mood disorders or psychotic illnesses. The comorbidity patterns reveal that the combination of mood disorders with substance use disorder or personality configurations. The critical insight that psychiatric illness represents a necessary condition for most suicidal behaviors underscores the fundamental importance of mental health treatment and suicide prevention efforts. Neurobiological and genetic factors. Recent advances in neuroscience have revealed the complex biological underpinnings of suicidal behavior, highlighting the role of genetic vulnerability in neurochemical systems and suicide risk. The serotonergic system has emerged as a central focus, with low levels of cerebrospinal fluid 5-HIAA consistently found in violent suicide attempters and suicide fatalities, including dysfunction in serotonin metabolism. Genetic studies demonstrate that heritability of suicide phenotypes, including ideation plans and attempts, range from 30 to 50%, indicating a substantial genetic contribution to suicide vulnerability. Key scientific criteria include impulsive aggressive traits, early onset of major depression, neurocognitive dysfunction, and heightened cortisol response to social stress. These endophenotypes represent intermediate traits between genes and disease that can be measured objectively and help individuals identify at elevated risk. Familial factors encompass both genetic vulnerability and environmental influences, with individuals at high risk more likely to come from families with history of suicide, mental illness, or substance abuse. Gene-environment interactions appear crucial in determining who develops suicidal behavior, with biological vulnerabilities potentially being activated or exacerbated by environmental stressors such as abuse or family dysfunction. Environmental and social risk factors. Environmental and social factors serve as important precipitants and moderators of suicide risks, though they rarely act as direct causes of suicidal behavior. Stressful life events consistently precede suicide attempts and death, but their impact depends heavily on individual perception and pre-existing vulnerability rather than objective severity of the stressor. Family environments characterized by disruption, conflict, physical abuse, or sexual abuse significantly increase suicide risk, particularly when combined with biological vulnerabilities. Access to lethal means, especially firearms, represent one of the most modifiable environmental risk factors, with ecological studies demonstrating strong correlations between method availability and suicide rate. Media coverage of suicide can create contagion effects, particularly among vulnerable young and youth adults, leading to cluster of suicidal behaviors following sensationalized reporting. The number of stressors may be more important than their specific nature, with individuals exposed to multiple adverse events showing elevated suicide risk. Social factors such as unemployment, incarceration, and social isolation often cluster with other risk factors, creating complex webs of vulnerability. In understanding these environmental influences is crucial for developing community-level prevention strategies that can reduce risk exposure and enhance protective factors. Protective factors and prevention strategies. Protective factors represent a cornerstone of effective suicide prevention, offering evidence-based approaches to reduce risk and save lives. Treatment of mental disorders, particularly mood disorders, provides significant protection against suicidal behavior, with medication like lithium showing particularly strong protective effects of individuals with bipolar disorder. Cognitive behavioral therapy and dialectical behavior therapy have demonstrated clear efficacy in reducing suicide attempts and suicidal ideation through structured evidence-based interventions. Means restriction strategies, including safe firearm storage and limiting access to lethal pharmaceuticals through packaging changes, have proven effective in reducing suicide rates at the population level. Provider education programs, such as those implemented in the Gotland study in Sweden and the U.S. Air Force Suicide Prevention Program, show promises for improving identification and treatment of at-risk individuals. Community and community-based approaches that combine multiple intervention strategies appear more effective than single intervention program, reflecting the multifactorial nature of suicide risk. Cultural factors such as strong moral objections to suicide and robust family support systems serve as protective influences, particularly in certain ethnic communities. The evidence clearly indicates that suicide is preventable through comprehensive, multi-treatment approaches that address both individual and environmental risk factors. Future directions and research needs. The field of suicide research stands at a critical conjuncture where significant advances in our understanding must be translated into more effective prevention strategies and clinical intervention. The development of standardized nomenclature for non-fatal suicidal behavior represents an urgent priority, as inconsistent terminology has hindered research programs and clinical communication. Future epidemiologic studies must integrate biological data collection with traditional behavioral assessments to take advantage of advancing in understanding endophenotypes and genetic contributions to suicide risk. The identification and characterization of protective processes at both individual and environmental levels remains severely understudied, yet holds tremendous potential for developing novel prevention approaches. Better prediction models for imminent suicide risk are critically needed to guide clinical decision-making and resource allocation in healthcare settings. The integration of technological advances, including digital biomarkers and machine learning approaches, may offer new avenues for suicide risk assessment and intervention delivery. Research must also focus on understanding how cultural and economic factors interact with biological vulnerabilities to influence suicide risk across different populations. Despite current gap in knowledge, the scientific foundation for suicide prevention is sufficiently robust to support immediate implementation of evidence-based strategies while continuing to build the knowledge base for future innovations. As we conclude this comprehensive examination of suicide epidemiology, it becomes clear that suicide represents one of the both profound tragedy and a preventable public health crisis that demands our sustained attention and coordinated response. The evidence presented throughout this discussion demonstrates that while suicide arises from complex interactions between biological vulnerability, psychological distress, and socio-political economic circumstances, our growing understanding of these factors provides genuine hope for prevention and intervention. The demographic patterns, risk factors, and protective mechanisms we have explored offer concrete pathways for developing targeted prevention strategies that can save lives and reduce human suffering. Healthcare providers, policymakers, researchers, and community members must work together to translate these epidemiological knowledge into practical interventions that reach vulnerable populations before crisis points are reached. The substantial economic burden of suicide, measured in billions of dollars annually, pales in comparison to the immeasurably human cost, yet both underscore the urgent need for comprehensive prevention program. Moving forward, our commitment to combine evidence-based approaches combined with compassionate care and community support can transform our understanding of suicide epidemiology into effective action that protects lives and promotes mental health across all populations, across all ages. The path to reducing suicide rate is complex but achievable, requiring sustained investment in research, prevention, treatment, and the fundamental belief that every life has value and that suicide is indeed preventable. Thank you once more for watching this video.